Hello, I'm Dr. Amrita Chakrabarty and I'm working as a hematologist in Max Hospital, Shalimar Bagh. We are here to talk about bone marrow transplant today. So what exactly is a bone marrow transplant? A bone marrow transplant is a special procedure. It is a special therapy for patients having blood disorders, cancerous or non-cancerous. What we do in bone marrow transplant is we replace the unhealthy bone marrow of the patient with healthy stem cells. Those healthy stem cells can come from the patient himself or from another donor. So these cells are taken from the bone marrow or from the peripheral blood. They are filtered, they are processed, and then they are given back to the patient after giving high dose chemotherapy. This process is called stem cell transplant. So you see, transplant of the bone marrow does not include any surgery. This is purely a medical procedure involving chemotherapy. So bone marrow transplant has been used successfully for a number of conditions, and we can use this procedure for treating blood cancers, also called as leukemias, lymphomas, multiple myeloma, non-cancerous conditions such as aplastic anemia, thalassemia, immune deficiency disorders, and also some solid organ cancers. So what are these stem cells and what exactly is a bone marrow? So stem cells are special cells and which make copies of themselves and change into many different kinds of cells that compose of the blood that we know of. Now stem cells are found within the bone marrow. The bone marrow is a spongy tissue which is found within long bones of our body, and these stem cells then differentiate into mature and specific lineage cells which eventually leave the bone marrow and flow out into the peripheral blood. When these stem cells, also called as hematopoietic stem cells, when they become diseased, when this is a disease condition, be it a malignant disorder or a benign disorder, and it can be a blood cancer, or maybe when the bone marrow stops functioning properly due to diseases such as aplastic anemia or a myelodysplastic syndrome, then it becomes important to treat that disease condition. Now, bone marrow transplant is not meant for everybody. We decide which patients are not likely to be cured by chemotherapy alone, which patients have a higher risk of relapsing and after treating with only chemotherapy, and which patients are eligible for this particular procedure. If we find that the risk of the disease coming back is higher with only chemotherapy, and if you also find that the patient is fit for at this transplant procedure, physically fit, the organs are functioning properly, and if we find a suitable donor, then we usually go ahead with transplant. This is a big commitment and it requires a lot of decision making both from the doctor and from the patient's perspective. So after evaluating very carefully, very properly, we take this particular decision. Now what happens over here is that, again, like I said, this bone marrow transplant is not a surgical procedure. It is purely a medical procedure in which the healthy stem cells are obtained from the patient, and then they are used to replace the diseased marrow of the patient. Now, which patients should, first of all, which conditions, which blood disorders are we looking at when we are talking about a transplant? Like I already mentioned, we consider blood cancers, which are also called as leukemias. Now, these leukemias can be acute, sometimes even chronic leukemias, like a chronic myeloid leukemia which has progressed to an acute stage, we consider for transplant. Besides that, other blood malignancies are lymphoma, multiple myeloma, which is a malignancy of the plasma cells. Other than that, there are certain immune deficiency disorders, then some solid organ cancers. Now, however, like I said, every patient is different in terms of their overall physical condition, their age, their comorbidities, organ functions, and also the disease severity, the disease type, the molecular type. There are some blood cancers which do not even need any kind of therapy. which are only kept under observation. There are some which are cured by chemotherapy itself. There are some which are more aggressive in nature and which have a tendency of coming back, relapsing. So in those conditions, we will definitely consider a transplant. Again, a transplant is most successful when we have a proper donor available, when we are talking about an allogenic transplant. Now, the donor is usually preferred to be a sibling who has a fully matched HLA type. If a sibling is not available, then we go ahead with we look for donors in the general population who have a similar HLA type as that of the patient. We call them matched unrelated donors. If that is also not possible, we can go for a half match transplant, which usually comes from parents or children who have a half HLA typing as that of the patient. The fourth type of transplant is a cord blood transplant, which is usually taken from the umbilical cord. So these are the types of allogenic transplant. Now, what is an autologous transplant? Autologous transplant is when we don't need a donor, when the donor is the patient himself. Now, in autologous transplant, we usually use this transplant for conditions such as multiple myeloma, lymphomas. So we give high dose chemotherapy to the patient once we know that the patient is in remission or the disease is gone. This high dose chemotherapy wipes out the bone marrow of the patient, but before giving the chemotherapy, we collect the stem cells from the patient who has already received chemotherapy previously for treating that particular disease or that particular condition. Once we take out the stem cells through a process called harvesting, we store those stem cells, then we give high dose chemotherapy to wipe out the bone marrow or the disease completely. Then it is important to re-infuse those stem cells that we had taken from the patient previously, because if we do not do that, the patient will not be able to produce blood on their own because of the high dose chemotherapy or the conditioning regimen that we give. Autologous transplant is comparatively simpler because we do not need an external donor. The risk of immunosuppression, risk of developing serious infections and other serious conditions associated, other complications associated with the transplant, such as GVHD or a graft versus host disease, is minimized with an autologous transplant. There are other diseases in which we need another donor, in which an autologous transplant is not appropriate. So when we need an external donor for the purpose of transplant, that is called an allogenic transplant. In allogenic transplant, like I said, we need a healthy donor, which can be a sibling, a parent, an offspring, or maybe someone unrelated to the patient from the general population who matches the HLA type. Allogenic transplant is usually done for conditions such as acute leukemias, aplastic anemia, or other diseases such as thalassemias, inherited marrow failure syndromes, and then certain immunodeficiency syndromes also. The next type of transplant that we use is an umbilical cord blood transplant. It is not used very regularly, but it is also another option for people who do not have a sibling or a matched donor. In umbilical cord blood transplant, the stem cells are taken from the umbilical cord of a newborn right after delivery, and then they are stored and eventually they can be used for transplant process also. Now, how is a donor and a recipient matched? Like I said, we usually do the HLA matching of the donor and the recipient, and we see how many of these genes are matching, and the more the better, the lesser risk of graft versus host disease. We usually look for 8 to 10 genes, but again, there are many other genes that we don't look for, which are less important for the process of transplant. However, the most important 10 genes we usually look for and we match prior to doing a stem cell transplant. How are the stem cells collected? Now, this is an interesting question because in the earlier days, stem cells used to be obtained from the bone marrow itself. The patient used to probably go into operation theatre and then under general anesthesia, and stem cells used to be collected repeatedly from the bone marrow, and a needle used to be inserted from the bone marrow and repeatedly stem cells were taken out. This process was done under anesthesia. Okay, so how are stem cells collected? There are usually two methods by which stem cells are collected. The first one is usually used more commonly these days. This is called a peripheral stem cell harvest, in which we give certain injections to the donor for 4 to 5 days, and then these injections are called growth factors. Through these injections, the stem cells from the bone marrow leave the marrow, and then they enter into the peripheral blood. From this peripheral blood, these stem cells are collected through a machine called the apheresis machine, and they are collected and processed and stored. And after that, once we give the conditioning chemotherapy to the patient and completely destroy the bone marrow, these collected stem cells are then infused back into the patient. This is a very comparatively a very minor procedure, and there are usually no complications except for a few complications involved with the collection process itself, and but usually they are associated with very minimum risks to the donor. The second type is also called the bone marrow harvest, in which the stem cells are collected directly from the bone marrow itself, and this used to be practiced in the old days, but these days we don't go for bone marrow harvest much, and bone marrow harvest usually used to be done under anesthesia in the OT, and multiple punctures were done in the bone marrow to collect the stem cells. But like I said, these days we prefer doing a peripheral blood stem cell harvest, in which we do not need any OT or anesthesia. We just give certain injections to the patient, which causes the stem cells from the bone marrow to come into the blood, from which it is collected ultimately. Then after harvesting or after collecting the bone marrow, what do? We give conditioning regimen to the patient. Like I said, conditioning regimen helps to completely destroy or completely wipe out the bone marrow of the patient, including the disease. And after once that is done, the patient is not eligible, the patient is not capable of producing blood on their own, so they need stem cells. Now the stem cells that we have collected earlier on from the patient himself in an autologous or from a healthy donor in allogenic, these stem cells are then infused to the patient just like we do in a blood transfusion. So after infusion, these cells gradually enter the bloodstream and then the bone marrow. They take a few days, maybe a week for autologous transplant, or 2 weeks to 3 weeks in an allogenic transplant to enter the bone marrow, and then they start producing cells on their own. They start multiplying and producing cells on their own. This process is called engraftment. So once engraftment is achieved, which means that the new stem cells which have been infused, they are completely functional and capable of completely remodeling the old bone marrow of the patient, and they start making cells on their own. So next we'll talk about some of the complications which are associated with bone marrow transplant, starting with the harvest procedure. So harvesting can cause some changes in the electrolytes, like the calcium levels. Also there can be some changes in the blood pressure or vitals, but usually these things are taken care of very meticulously during the harvest procedure. Next, during infusion of the stem cells or the transplant procedure itself, there can be chills, fever, pain, risk of infection or sepsis, and some allergic reactions associated with the additive solution that we use to process the stem cells. Next, after infusion, the patient usually goes into this deep neutropenic phase because they are not able to produce cells on their own, and it takes time for the new marrow cells to go and start producing cells on their own or to start functioning. So this time duration between when the bone marrow is not functional of the patient and when the new cells start functioning, the patient is not able to make blood on their own. So there is a high risk of infections because there are no WBCs, the patient will need repeated transfusion in the form of packed red cells or platelets, because they are not able to produce red cells or platelets either. The risk of infection is much higher. The risk of the infection developing or progressing fast is even higher because of the low immunity of the patient. And again, other more common situations associated with a transplant or chemotherapy associated complications can be nausea, vomiting, and again, repeated infections, fever, low count, and complete loss of appetite. There can be mucositis, there can be these blisters in the mouth, there can be loose motions, diarrhea, constipation, and need for frequent transfusions and transfusion associated adverse effects also. For example, transfusion associated hemolytic reactions or non-hemolytic febrile reactions. So what are the long-term complications that can happen following a BMT? The most important one over here is something we called a GVHD, or a graft versus host disease. This complication is usually seen in patients undergoing an allogenic transplant. So there can be skin problems, there can be liver issues, and there can be kidney issues, and the next complication is maybe the graft stops functioning at a point of time, which is also called as graft failure. There can be relapse of the disease if adequate stem cells are not infused. Then the fourth and most important adverse effect or complication of transplant is always a high risk of mortality, which is not to be ignored. The mortality risk is again much higher with an allogenic transplant compared to an autologous transplant. So these are basically the complications associated, and again, over a period of time, the bone marrow may not pick up, and the patient may need repeated transfusions again to maintain the bone marrow. They may need repeat infusions of white blood cells, also called as donor lymphocyte infusions, for the marrow to get functional. GVHD can also progress to a chronic phase called chronic GVHD. Also increased risk of certain infections, certain viral infections or opportunistic infections because of prolonged low immunity to the patient and prolonged use of immunosuppressants. Okay, so having said all this, still bone marrow transplant has come a long way in the past few years, and there are much better antibiotics available to us and much better supportive care, and again, the risk of infections, the risk of other complications developing as a result of transplant is minimized, and because of improved care facilities that are available these days, and because we understand the pathophysiology of the disease better, and the chemotherapies and the antibiotics and their mechanisms and their interactions much better, the mortality rate has dropped significantly. So bone marrow transplant, although it may sound like a risky procedure, and it may be to a certain extent, but it can also completely cure a blood condition which otherwise has no cure. And it can also offer a normal life expectancy to a patient who would probably not have it with chemotherapy alone or without a transplant. So bone marrow transplant can completely cure a blood condition, can offer a normal, healthy lifestyle or a healthy or a normal lifespan to a patient. But it is very important to select the patient very, very carefully to decide who actually needs a transplant and who doesn't need a transplant. So if any patient you think, or if anybody you know who has a blood condition, then it is very important that you meet with your hematologist and you decide that what needs to be done, whether the patient needs to be treated, not treated, or treated with chemotherapy alone, or a transplant is needed, what kind of a transplant is needed, what are the risks associated with the transplant, what is the life expectancy, when can you expect to start having a normal life again. So these are the questions you need to sit and talk and discuss with your doctor before before losing hope when somebody is diagnosed with a blood condition. So definitely bone marrow transplant offers a lot of hope these days, and we have seen a lot of success stories, and we expect to see much more with further evolution of technology and further evolution of our medical science. Thank you.